I'm Matt, by the way, with Maxius. I'm most excited about this one. I don't know if my speakers are as excited as I am. I think they're slightly nervous, so let's be nice. We've been doing this resident contest this is our 4th year. And we decided to transition our 4th corporate forum into allowing these residents to showcase their work and what they've been doing. And the 5 you'll hear from today are our finalists for our resident contest this year. They're all vying for the coveted belt here. So if you see somebody wandering around in it later, you know they won. So we'll be announcing the winners a little bit later on today. I'm also joined with Dr. Katherine Carmona Hernandez. She is going to be moderating the session today. She's got some great questions. I think there's going to be some lit review, so no, I'm totally kidding. All right, we'll go ahead and kick it off.
All right, thank you so much, Matt, for this. So everybody kept asking me about this clinical competition, and here we are, ready. So on behalf of Maxius, I would like to welcome everybody to this exciting and groundbreaking clinical competition. As Matt says, in previous year, this BioXclude competition took place behind closed doors, but this great company has taken their support of innovation and excellence in periodontology a step further by giving these 5 finalists the opportunity to present their clinical cases here. So we have 5 finalists, and each is going to have 8 minutes to present their cases, and after that, I will ask a question. So as you can imagine, for us, this is more than just a competition. It is a special opportunity for all of us to come together, share insights, and be inspired by these young clinicians. So thank you again, Maxius, for making this incredible event possible. And thank you, everybody here, for joining us to celebrate these remarkable professionals. So with that being said, let's get started with some fantastic cases. In first place, we have Dr. Priscilla Young from UCLA.
Hi, good afternoon, everyone. Thank you so much for being here. I'm Priscilla. I'm a 3rd-year resident at UCLA. I want to thank everyone, including Matt and the entire BioXclude team, for hosting this competition for us to kind of talk about a little bit of why we like to use BioXclude. So BioXclude can be used for so many different modalities, and I'm going to talk a little bit about some of them. So my first patient is a 60-year-old male who came in with multiple carious lesions on his lower anterior dentition, as well as a fractured number 12 and severe bone loss around number 15. We extracted number 12 and number 15, as well as all the lower dentition. We are planning to move forward with implants, and during implant treatment planning, we had a CBCT, which had an incidental finding of a cyst. Now, the cyst was in between number 3 and number 6 in a location that we didn't plan to place an implant. So what we found over here a little bit closer was that both teeth were actually vital and that the probing depths were about 3 millimeters. Here's a closer look at the CBCT. You can see that it's about 8 millimeters in dimensions all the way around. There's thinning of the buccal cortex as well as the sinus floor. And so we plan to move forward with a biopsy of the area just to evaluate and to see what's going on. So after a flap elevation, you can see during cyst removal, the cyst had actually ruptured, and you can see the creamy white and yellow substance. It was keratinaceous in the area. This is just continued cyst removal, and there is the cyst in its entirety. This is the intrabony defect that was left in the area. You can see in there that it's very close to the sinus floor. It was very, very thin, thinner than an eggshell. So in terms of the cyst, a little bit of a closer look, you can see in terms of the histology report, there was a hyperchromatic and palisaded basal cell layer, as well as a perikeratin layer on the top, which is very incidental for odontogenic keratocysts. Following the removal of the cyst and removal as much as we could of the cystic epithelium layer, we actually took a BioXclude membrane, folded it in half, and placed it in there. Part of the reason why we really enjoy using BioXclude is because of how well it adapts to no matter where you put it. That shape was really interesting, and it kind of morphed right into it. We followed it by placing freeze-dried bone allograft into the intrabony defect and packed it a little bit more. And you can see we layered another layer of BioXclude on top, and you can see just how well it's adapting in the area. We can see over here we were able to attain primary wound closure even with the overpacking of the FDBA, and this is the immediate post-op radiograph. We wanted to keep a close eye on the patient, so we followed up at multiple weeks as well as a month and a half, month 2, and month 6. Now we did get some recession, but what we're happy about is that compared to preoperative, you can see that the bone fill is still present. We followed up with a CBCT just to keep a close evaluation, and fortunately, we don't have any signs of reoccurrence currently. Now, we plan to continue to monitor the patient regularly for a CBCT to evaluate any reoccurrence, but so far, we're very happy with the results, and part of the reason why we like using BioXclude. You can see a bit of a comparison here in terms of different views and how there's no view of any cystic lesions and how there is bone fill in those areas. Moving forward, other reasons why we like using BioXclude. A 70-year-old Hispanic male came in, ASA classification 2, with a concern of his lower front tooth. In terms of the radiograph, there are multiple areas of concern, of which are the lower anterior areas as well as the upper left posterior. Let's focus a little bit on the lower anterior area. So here we have a endoperiolesion lesion of number 24 with complete bone loss and severe bone loss on number 23 and number 25. You can see on number 27 and 28 we have some intrabony defects in the area with probing depths around 6 to 7 millimeters. Here is flap elevation and degranulation. We can appreciate how deep those intrabony defects are. Freeze-dried bone allograft was placed into the area and followed by a BioXclude membrane. Part of the reason why I really enjoy using BioXclude is being able to place them in between teeth without worrying about any flap closure in the area, limited worrying about any swelling of the actual membrane in itself, and how easily it stays in that area. So focusing on site number 24, you can appreciate that the buccal and lingual cortices are completely gone. We placed freeze-dried bone allograft in the area, followed by a non-crossing collagen membrane. Here is primary wound closure that we were able to achieve and the immediate post-op radiograph. So here we followed up at week 1, week 2. Patient disappeared and surprisingly came back at month 9. And we can see that over here, the probing depths at number 27 and 28 had reduced to about 3 millimeters with very minimal BOP, or bleeding on probing. So we have the preoperative radiographs, and let's do a comparison. We can see bone fill in all areas. Really awesome. So at 9 months, we wanted to move forward with the implant. That's probably why the patient came back. So the ridge seemed to be a bit thin, so we wanted to move forward with a ridge augmentation. Luckily so, we were able to re-enter at least 2 of the sites that we treated. And you can see here, especially focusing on number 27, that originally we had those intrabony defects, and clinically, we also had that bone fill in that area. Really nice. Number 24 area, big comparison over there. We were able to gain back a lot of bone in that area. So moving forward, after full thickness flap elevation, we had a layer of freeze-dried bone allograft, followed by DBBM onto the area. We placed a non-crossing collagen membrane both horizontally and vertically in between 23 and 25. And here comes our BioXclude with our smiley faces layered right on top, and you can see just how well it forms right in that area. We wanted to place that on top to allow for all the biologic modifiers to be able to kind of shine and help with the wound healing and cell migration in that area because it was a large surgery. We have primary closure in that site, and then we have a 1-week post-op here at week 3 as well as month 2. So, in comparison, we're moving on to the next area of concern, the upper left site of number 11 and number 12. Probing depths of about 7 millimeters with intrabony defects. We had a full thickness flap elevation in the area. Here you can appreciate the depths of those intrabony defects. We placed freeze-dried bone allograft again, and then BioXclude membranes poking right there, and all it was just a nice easy pull right over the buccal of the bone graft. We were able to achieve primary closure, and at week 1, you can just really appreciate how well that tissue is healed. I mean, it looks like we never entered that site. Let's talk about month 5, still looking very nice. Swelling has gone down in that area. And at month 7, the probing depths were decreased to about 3 millimeters. So here we have our preoperative radiographs. And we have at month 5 that radiographic bone fill in the area. So overall, very different reasons why I like to use BioXclude, and here's are just some of them. I want to thank you guys for this opportunity, and thank you, Dr. Hamada, as well as Dr. Lin, for your contributions.
All right, Dr. Young. So are you ready for your question?
Yes.
Okay. So how did the BioXclude membrane aid in managing the defect, and what was the impact on tissue healing and regeneration?
Yeah, that's a great question. So one of the reasons, as I said, that I really enjoyed using BioXclude is just how well it adapts to no matter what area you're using it at. Whether you're using it at a base layer for the OKC defect or whether you're placing it on top, there's less of a worry about it touching the root surfaces of the adjacent areas and allowing for flap adaptation. And another reason why I like using it, as I talked about, is that it has all these biologic growth factors, TGF-beta and things like that, that kind of promote that wound healing, angiogenesis, and mesenchymal cell migration to the area, which really promotes how quickly the patient's healed and limited the amount of inflammation and kind of discomfort the patient felt.
Thank you so much for your presentation.
Thank you.
So to continue, we're going to invite Dr. Agata Lunowski from the VA Greater Los Angeles Healthcare System.
Hi, my name is Agatha Wisniewski, and I'm proud to have served our nation's veterans at the West LA VA. Thank you for joining us today to talk about BioXclude, the dehydrated human deepithelialized anion chorion membrane, serving as a barrier, conduit, connector, and cushion in periodontal regenerative procedures. So I had the privilege of working with BioXclude for the past 3 years, and I'd like to present to you one of the cases that I was able to be a part of and had documented from start to finish. When the patient presented to me, he was a 78-year-old man whose main concern was the edentulous space on his lower left. He was interested in a fixed plan and wanted to know what options were available for him. The patient's medical history was significant for adenocarcinoma of the prostate, sleep apnea, amputation of leg, and mental health history, all of which was taken in mind when treatment planning this case. So this is how the patient presented on initial presentation intraorally. This edentulous space displays horizontal loss, so the ridge is narrow, resembling a knife edge appearance, lacking sufficient width to support an implant, as well as some vertical bone loss here. There is significant loss of height, making the ridge shorter and affecting the overall contour. This combination poses challenges for prosthetic rehabilitation, often requiring grafting procedures to create a suitable foundation for implants. In such cases, careful treatment planning is essential to restore function and aesthetics. So the scan and radiograph here coincide with what was seen intraorally, with the loss of vertical height in the bone between teeth numbers 18 and 21, resulting from the natural resorption of the bone that had taken place once these teeth became missing. So to address the patient's chief complaint, and with the goal in mind, I treatment planned 2 implants, a 4.1 by 8 Straumann bone level tapered implant at site 20, and a 4.8 by 8 Straumann bone level tapered implant at site number 19. With the treatment plan, I knew that there was not sufficient width to place implants of these dimensions. So following the guidelines that the ideal buccal bone around the implant should be about 1.5 to 2 millimeters, and that 1.1 to 2 millimeters on the lingual. I knew that I had to perform a ridge augmentation procedure in this case. The current ridge did not have adequate width and bone for these implant sizes. So I knew that a ridge augmentation augmentation procedure would allow me to widen this ridge and restore a significant amount of the loss in width. And based on the images seen in the CBCT and the measurements that were taken, I decided that a two-stage approach would be more optimal to enhance the healing and improve the predictability of the outcomes, as well as to refine the aesthetics for better soft tissue management. So for this ridge augmentation, I made a crestal full thickness incision to a split thickness incision extending from the distal of 18 to the mesial of number 21, with a vertical releasing incision on the mesial of 21. I reflected a full to split thickness flap and achieved relative passivity of the flap. I then reevaluated the area and confirmed that the ridge was reflective of what I had seen on the CBCT, and I was able to move forward with the planned ridge augmentation procedure. I then performed intracortical perforations with a half round burr. After the perforations, I placed a combination of 50/50 BioX and mineralized cortical powder on top of the ridge defect from 19 to 20 for structural support, osteoconductive characteristics, and reduced resorption time. So this was then covered with the BioXclude amnion chorion membrane, which quickly adhered to the area, but also allowed for enough time to still be manipulated into the ideal position, while also eliminating the need for tacks or any other membrane material. I then sutured the site closed with Gore-Tex simple interrupted and continuous mattress sutures. And here we can see the results of the 2-week post-op. So I can appreciate signs of normal healing of the surgical site with the suture still intact, and visually I detected an increase in the volume of bone in this edentulous area. Here we have a pre-op and post-op radiographic comparison. So in the post-op radiograph, it appears to be more radiopaque in nature compared to the pre-op, showing changes in the bone density and volume. And the proof is in the pudding here. So the measurements that were taken with a probe were taken from start to finish. Immediate post-op measurements measured 1.5 to 2.5 millimeters in horizontal gain. The 3-month post-op measurements demonstrated a 1 millimeter to 2.1 millimeter gain. And finally, at the 8-month post-op, there was approximately 0.7 to 1.8 millimeters in horizontal gain across the edentulous area. So the success of the ridge augmentation with the use of the BioXclude membrane provided me with the ability to place 2 implants at the site with ease. Primary stability of the implants was achieved thanks to the quality of the bone from this ridge augmentation with BioXclude. And here's how the patient presented at the 2-week post-op, post-implant placement. So there was no pain, no swelling, some soft tissue overgrowth on the healing abutment, but very happy to see these results and overall success in more ways than one. And some takeaway points from this case here. I can't stress enough the adaptability, the flexibility, the generous size, and the biological properties of BioXclude made this ridge augmentation both easy to work with and comfortable for the patient. The results of the ridge augmentation were statistically significant with a 0.7 to 1.8 millimeter gain in horizontal width of bone. And most importantly, the patient was happy. The patient stated that he did not experience any discomfort, and the patient was ecstatic that his chief concern was addressed of receiving teeth in the lower left. Therefore, with these positive results, and with the patient being as happy as he was, as a provider, I was happy too, and I recommend this treatment option regularly. Thank you very much for your time, and I hope that this case presentation demonstrated for you all here one of the many ways in which BioXclude can be used. And I'd like to thank my program director who worked with me on this case, as well as my attending, Dr. Tomo, who has been my mentor. And Dr. Negi, thank you.
Thank you for that presentation. So in your GBR case, how did the BioXclude membrane contribute to the outcome of both bone turnover and implant placement?
So I believe that because the membrane was able to keep the graft material in place, the success of the procedure was in the BioXclude adhering to the area well and keeping the bone graft material where I wanted it to be. And so therefore, because of that, I was able to eliminate the use of tacks as well as any other kind of membrane material. And I felt as though the adhering qualities of this membrane, its adaptability, and just its large size made it easy to be able to just use one membrane that was able to stay in place.
Great, thank you for that answer.
Thank you.
All right, so our next presenter is gonna be Dr. Chong from Michigan University.
Good afternoon, everyone. My name is Yichen Zhou Chang, and I recently graduated from University of Michigan Grad Perio program, and currently I'm working in private practice in Tacoma, Washington State. So today I'm very excited to share with you one of the cases that I did in the residency program, that we used the amnion membrane to manage the periodontitis, the defect, and then we did this surgery under the operating microscope. So some general information for the patient. The patient is a 77-year-old Caucasian female, and she has hypertension, she has arthritis, everything is pretty well managed with the medication. She is a non-smoker, which is very important in this case, and she has a low smile line. So she referred to our clinic from the dental student clinic that she has some discomfort when she bite down on the implant, and also during the student examination, they saw that there's radiographic bone loss around the implant. So when I saw her, she told me that the implant number 10 was actually placed in 2007. So during the perio chart clinical exam, we see that the probing depth is ranging from 8 millimeters to 12 millimeters. And we confirmed the clinical examination by the PA. We see that there's radiographic bone loss, almost like 50%, actually 50% of the bone loss in this area. And we confirmed this by CBCT that the implant is actually lacking of buccal bone. The patient told me that she really wants to save this implant. She loved her implant, and so we were like, okay, this is a very optimistic patient. So as an optimistic periodontist, we told her that, oh, actually there's a silver lining here, and actually in this case, there's a bony lining here that we can see right here. There's a chance because we can see like the interproximal bone peak on the mesial area and also on the distal. And there's some slides that probably palatal wall in the back as well. So we told the patient we can try to do the reconstructive method. So the goal of the surgery for reconstruction is that we want to resolve the defect by reducing the probing depth to less to equal to 5 millimeter without the BOP. So at this time of surgery, we removed the implant crown, and we saw that there's pus at the time. And we did the surgery under the microscope, so we used the ophthalmic knife for the sulcular incision, and then using the 15C blade to remove the granulation tissue. So after we elevate the flap, you can see, well, not only the implant was gathering all these memories from 2007, but also we see that there's a lot of plaque and calculus around it. So under the microscope, we were able to see it very well that we can use the piezo and also the erythritol powder to do the debridement and also the decontamination. So this is a clear view of this implant defect that you can actually see that there's interproximal bone height on the mesial side as well as the distal side. However, the height is a little bit lower than the mesial. And we can see that there is actually a palatal wall here presented after the debridement. Another view that you can see on the occlusal view, so you can see the interproximal bone here and also on the distal and the palatal wall. And to analyze this implant position a little bit, the implant actually plays a little bit too buccal. So here comes the smile. We use the BioXclude amnion membrane. How we use it is that because the bony dehiscence on the buccal side, we have to tack the membrane using the tacks. And then we augment the bone graft under the amnion membrane with cancellous bone graft, and then we adapt the membrane underneath the flap, which is very easy to manipulate because of the character of the amnion membrane. There's no need for trimming and everything, so it's also okay to touch the tooth as well, so it's very easy to manipulate. There's some extra additional fixation using the 6-0 polypropylene suture as well on the flap, just to ensure that the healing is stable. And due to the characteristic of the amicroring membrane, we keep this healing using the secondary intention healing because there's previous research showing that there's successful open wound healing, GBR in this case. So in this case, we also do the open healing. At 2 weeks, all the sutures, they're actually still in active function, so we didn't remove any suture. We did remove most of the suture at 3 weeks, except for this tiny one on top of it because it's still in active function. So what is unique for this case is that we were able to follow through the wound healing. Actually from the before surgery, 2 weeks, 3 weeks, 2 months, 3 months, 6 months, we're able to use the ultrasound to monitor the wound healing underneath the flap without invasive flap entry. So we designed this guide using the CBCT overlay with the intraoral scans, and we want to make sure that ultrasounds, this guide, we can always take the scan at the right mid-facial level, just to keep it consistent. So at 3-week scan, as you can see here, those two are the same ultrasound scans, but I want to show you. So this is the implant threads. This is the bone that we reconstruct, and this is the soft tissue. So at 3 weeks, it shows pretty stable healing at this point. And also from the facial view, you can see that the implant surface is right here. Bone graft is reconstructed to almost like the first thread, and also the soft tissue is pretty stable as well. At 2 months post-op, the patient has increased so much better with the oral hygiene, and yeah, she's doing a great job doing the oral hygiene like her New Year resolution. So we also were able to do the ultrasound scan as well. At 2 months, occlusal view and facial view, we were able to see the bony reconstruction, which is pretty stable on both of the views. 3 months, the patient come back. Hygiene is also still really good, and same thing, we did the ultrasound scans, and also we took some periapical radiograph to confirm the radiographic finding. So at this point, we did see that there's radiographic bone fill at the mesial almost, this is almost to the first thread actually, and then the distal side, the reconstruction is almost to the second thread, which is normal because when we saw this patient in the beginning, the distal interproximal bone height is actually lower than the mesial side. So the ultrasound also shows that the bone level is pretty up to the first thread and also the implant platform. Here, pretty stable as well. The patient came back at 6 months. She's really happy, and we're happy with the results as well. And we also did the ultrasound again. This is the occlusal view that we were able to see that the bone is reconstructed also almost to the implant level. Really good reconstruction, and also on the facial view, it is the same as well. So we put the implant crown back for her. She's really happy, although there's some recession going on because we had the surgery. She has this low smile line, so she didn't mind, and she's happy that we saved the implant. So clinically, we want to conclude is that pre-surgery, we see that there's defect level is intrabony defect and also circumferential and also buccal dehiscence that we see. But at the 6 months post-op, we see that the bone is reconstructed. Almost this one on the mesial is on the first thread, and the distal is to the second thread. And all these probing depths, they're ranging from 4 to 5 millimeters, which we probe with the implant crown in. So I will say this is a success. So to conclude this case, the pre-surgery ultrasound that we did is you see that the implant thread is right here. This is the implant crown. And the bone is all the way down there is 50%. And at the 6-month post-op, we see on the ultrasound, you can see the bone is reconstructed all the way back. And what is unique for ultrasound is that we can also evaluate the volume and velocity of the blood flow, which indicating to the degree of the inflammation. So in this case, I compare the pre-surgery and the post-op. There's way more signal for the blood flow around the pre-surgery compared to the 6-month post-op. So I want to thank you guys for being here and listening to our case, and I want to thank my program director, Dr. Honglei Wang, and also my mentor who supervised me on this case, Dr. Albert Chen, for this. So I hope this case left you a smile for saving an implant, and so as our patient, and also as the BioXclude membrane. Thank you very much.
Thank you, Dr. Chan. So we know as clinicians that treating perimplantitis is very challenging. So that being said, in your perimplantitis defect reconstruction, what role did the BioXclude membrane play in achieving successful regeneration, and how did it affect the long-term stability of that implant?
Yes, so I'll say what is very special for this case is that we actually experimented a little bit to leave the healing, secondary healing, because from the previous research, it shows that it can be used by the open wound healing for ulcers, leg ulcers, or any like burn patient is easy to use. So there's also previous research by Dr. Yu that they did the amniocorium membrane with the open healing GBR. So in this case, because around the implant, sometimes it's really hard. If the patient wants to leave the crown in, it's even harder for the primary closure. So in this case, the BioXclude membrane is actually, I'll say it's a really good treatment option for the patient because it is able to manage the open healing really well and also adapt around the defect really well, no matter if it's circumferential defect or it's super bony defect. It actually adapted pretty well, and it can be tagged as well, which the thickness is pretty good. Even if you do the tag, it doesn't break, it doesn't tear. And with the growth factors and the PDGF, VEGF, those, all the things we want to try to save this, it's almost like a miracle. So I'm glad it worked, and I believe the patients are really happy. The patient is really happy too.
Thank you so much
Yeah,
for that.
thank you so much.
So now we are going to welcome Dr. Daniel Ryan from Texas University.
All right, everyone. Welcome to my case, my best BioXclude case presentation. I'm Daniel Ryan. I'm a third-year periodontics resident at Texas A&M, and today I'm going to talk about my best BioXclude case, which was a GTR on tooth number 19, which presented with a grade 2 furcation. So this patient was referred from prior practice, and she came in with a temporary prosthesis from number 19 to 21, and the referral mentioned about a isolated deep probing depth on the buccal of tooth number 19. This patient, as per what the referral note said, was receiving hygiene care at that office, and the defect itself, as it shows over here on this limited periodontal charting, presented with a 5 millimeter probing depth. So the referring doctor sent us x-rays, and we had x-rays pre-preparation and after preparation, but the focal radiolucency was evident on obviously both pre and post-preparation x-rays. And then, unfortunately, the defect was, and the radiolucency was only noted after preparation. So, clinically, factors that I noted were there, obviously, gingival inflammation, edematous gingival margin, and there was also plaque buildup, so oral hygiene wasn't the best in this case. So, patient was, we instructed, gave her oral hygiene instructions, and proceeded with and proposed to her a regeneration approach on that tooth itself, since it was already deep in the restorative process. And again, clinical examination showing the 5 millimeter periodontal pocket with bleeding on probing, and you can also tell she presented with a thin gingival phenotype. So I did an intrasulcular incision, and I extended it about 5 millimeters distal, and I attempted to do a mid-crestal incision. I avoided to remove the temporary prosthesis, and then I extended that incision measly and not going all the way to tooth number 21. But upon flap reflection, it was obvious there was granulomatous tissue, there was marginal bone loss, a little bit more evident towards the mesal root, and what stood out for me was the grade 3 cervical enamel projection. And so after granulomatous tissue removal, you could tell that that projection was already all the way into the furcation, and there was also some calculus buildup mesal to it. So what I did was I removed all of the projection with a high speed, a carbide burr. I made sure and was careful not to attempt to not have any pulpal exposures. The patient was worried about potential sensitivity after that. I use a piezoelectric instrument to remove any residual calculus, and as well as all the granulation tissue. And you can see that the marginal bone there's more marginal bone loss on the mesial root. So for site analysis, factors that I was observing before even attempting regeneration of this site was, a limiting factor was the fact that this patient presented with a short root trunk. So that was going to add some difficulty later on to maintain this area. However, she had good interproximal bone height relative to the furcation defect. And I could tell with this picture that was, and even clinically, that I had done a good job with removing all the granulation tissue. So I felt like the site was in a good condition to get a bone graft done. So materials that I chose were, first one was my BioXclude, my deepithelialized amnion chorion membrane, as well as the bone graft of choice was Encore, which was a DFDBA, FDBA 70-30 mix, as well as my biologic of choice, which was PDGF. So I soaked my bone graft material 10 minutes prior in the biologic solution, and I placed it, attempting to sculpt as best as possible the bony architecture, and I overpacked it as well, knowing that I would lose some bone graft at time of healing. And I laid my BioXclude membrane over in an attempt to protect my bone graft particles, and as well as to reduce inflammation because of the properties of this membrane, and as well to it had a great adaptation factor in it, so I could actually lay my flap over it and avoid possible dehiscence in this case. Especially because since the case was already prepped, I wanted to avoid developing recession over here. So I sutured this case. I used a sling suture. I attempted to coronally advance where number 19 is. So I used glycolon sutures, 5-0, and also used 2 simple interrupted sutures, mesial to where tooth number 19 was present. And I brought the patient back in for 2 weeks for follow-up, and I was very happy to see how well the tissue had responded. Minimal inflammation was evident. The patient did a good job with oral hygiene considering what the procedure that was done at the time. And I was pleased to see not a lot of recession and actually some coronal migration of the gingival margin distal to tooth number 19. I brought the patient back at 1 month. The patient forgot to follow instructions as far as stopping rinsing with chlorhexidine. So that was discussed at that appointment. And I was still very happy to see the level of the gingival margin where number 19 is. So no probing was done at that appointment yet. And then finally, I brought the patient back at the 6-month follow-up, and probing was done at that time, and a 2-millimeter probing was noted. Still with bleeding on probing, so oral hygiene instructions were reviewed with patient again. And patient was referred back to her restorative doctor for delivery of the final prosthesis at the time. Great job with shade matching and contours, and as well as keeping the prosthetic margins supragingivally. So cleansability was able to be achieved by the patient and with proper home care. However, patient, after delivery of the bridge, opted to have implants done in other sites that she was missing teeth. Even though she liked her bridge, she was looking for something a little bit more natural. So next step was, okay, let's take a CT scan. So since I was going to take a CT scan no matter what, I wanted to have a look at where our surgery was done. So I was happy to see that and the next couple of cross-sectional views, I had really good bone fill in the area. Axial view showed, I was happy to see that there was bone fill as well over there. And finally, with the software that we use for implant planning, AI allows us to do, it does a segmentation of the bony and dental structures itself. So I asked that software to do it for me, and I was able to see that there was good bone recovery, especially with where the mesial, on the mesial root where there was marginal bone dehiscence, and there was recovery of differentiation bone level as well. All right. Well, I'd like to thank everyone for being here, my program director, Dr. Crump, my co-residents, and for the opportunity to present today.
So that was a beautiful GTR case. So what specific challenges did you face in your case, and how did the BioXclude membrane enhance this regenerative process for you?
So the membrane itself helped me because this case was an ongoing case already. So I was limited by how the preparation for the bridge was done. So the membrane helped me with reducing the inflammation and having good and faster soft tissue healing in order to minimize potential recession. Even though the patient was made aware of that, I believe that this membrane really helped me to get the surgical outcome I got.
Okay, thank you, Dr. Ryan.
Thank you.
So last but not least, we have Dr. Yi Swan from UNC.
Dr. Ryan, do you have the clicker? Thank you. All right. Hi, everyone. Thank you for coming, and thank you for everyone over at BioXclude for letting me be a part of this competition. My name is Jesse Wu, and I was part of the UNC grad perio class of 2024. For this case today, my patient was Mr. DR. He was a 65-year-old male, and he presented with the chief complaint that he would like to get implants to replace his missing teeth. His medical diagnosis was significant for hypertension, hypercholesterolemia, and hypothyroidism, all of which were controlled with the following medications. He had no known drug allergies and was a non-smoker, so I would classify him as an ASA2. This was his initial clinical presentation, and he wanted to address both the maxillary right as well as the mandibular left, but just for today, we'll be focusing on the maxillary right. He had reported having a history of deep cleanings, but at the time of our exam, he was periodontally stable. Upon entering the school, a panoramic radiograph was taken, so this was what we had at our initial visit, as well as a full mouth series. And then knowing that we were planning to do some implants, I took a CBCT on him, and this was sort of the initial views here. I also took some intraoral scans to help me in my digital planning for those implants. So this was my preliminary implant planning. I know the measurements are kind of small here, but at the number 3 site, there was approximately 5 millimeters of crestal bone, and I was aiming to put a 10 millimeter implant and sink it a little bit subcrestally, about 1 millimeter. So because of those things and me being a resident eager for sinus lifts, I decided to use a lateral approach. So I treatment planned him for sinus augmentation with a lateral approach and 2 implants. So at the time of surgery, this was his preoperative condition. And this was my incision design here. You can see the maxilla and the crest there with the flap reflected, as well as my window outline. The Schneiderian membrane was elevated with no complications there. I grafted it with 100% xenograft, and then placed my 15 by 25 millimeter BioXclude membrane over the window. So the reasons why I decided to use a BioXclude membrane in this case was mostly for its adaptability. I placed it dry, and it kind of adapts as it hydrates, and I like doing it this way just because I find it a little easier to situate it when it's dry. As it hydrates, it also kind of sticks to the area that you place it, which is nice as far as keeping it sort of stable, but I also know that if I wanted to move it around, I could push it or pull it around, and it kind of slides. I'm not worried about it tearing because it's pretty tough, and it's also flexible enough to stay contoured along the bone there. It's also very easy to fold if you want to fold it between teeth, and just very easy to use. So, you know, I also didn't feel any kind of need to trim it. You can see that all the corners are still there. There's no up or down side, so you're not worrying about like which side do I have to put up. In my case, I didn't feel any kind of need for fixation, just because it sticks so well to the bone, and I also was not concerned at all with it touching the tooth there. One other big benefit to me was the bioactivity of it. The release of growth hormones helping to aid in soft tissue and hard tissue healing and regeneration was a big benefit, and also helping to prevent any kind of infection. So this was the area all closed up. And then the 2-week and 5-week post-op, you can see that he had really good primary intention healing at 2 weeks. It was just a really unremarkable healing. He didn't complain of much pain, much swelling, anything like that. There was definitely no infection, so that was making me feel very good moving forward. So 5 months after the sinus augmentation, we took a new CBCT, and zooming in a little bit, you can see in the area that we did the window, which is kind of where those slices are, that cortical bone looks very continuous. You don't see any kind of radiolucencies from where that window was, so it's kind of suggesting that the cortical bone had reformed. And then this was my final implant planning. So upon re-entry for the implants, you can see that that cortical bone had really reformed. It was hard to even see kind of where that window outline was, and that whole area of bone was really solid. So that was making me feel good about going into placing the implants. I placed 2 implants, and we got really good primary stability, over 35 Newton centimeters, so decided to place some healing abutments. And you know, nobody's perfect. I think I sutured my flap a little bit too coronally over that number 3 implant, so I lost a little bit of the keratinized tissue there during the healing process. So, you know, I wouldn't be a periodontist if I didn't mention the tissue. So because of that, and the lack of good attached tissue over the mesiobuccal root of number 2, we decided to also just add a free gingival graft to help protect those implants. So I waited till after it was restored. The bridge was done by the UNC Graduate Operative Department, and then did a free gingival graft in that area, and that's the 2-week healing. I graduated shortly after this, so I wasn't able to follow it up anymore, but the patient was thrilled with the whole process. He was happy about everything, and he was just mostly really happy to be able to chew again on his right side of the mouth. So I want to thank you guys all for coming and supporting us, and I want to thank my program director, Dr. Suzine, and also my co-residents who probably took half these pictures. So.
So thank you, Dr. Wong, for that beautiful performed case. So for this lateral sinus elevation procedure, can you discuss how the BioXclude membrane facilitated the healing process and the integration of the future implant?
Yeah, so I think the key here was that we had really unremarkable healing. I feel like the growth factors in the membrane really helped with the flap just healing with good reattachment to the surrounding bone, getting good primary healing, preventing any kind of infection, and just keeping the window really well covered and keeping all that bone graft well situated in there, and just letting that heal for several months with the addition of the growth factors really helped to really just make that bone graft nice and stable and strong.
Thank you so much for that.
Thank you.